it is divided into drug sensitive and drug resistant. Okay. Sensitive is one which is sensitive to all four drugs. The main four drugs are HRZE. Resistant is if you get on the basis of NAT, that is the nucleic acid amplification test, if you get R resistant. But in general, what is the MDR-DB? MDR-DB is one which has resistance to both H and R. Okay. Or others, if there is any resistance, then it is called, it is a single drug, mono drug resistance, poly drug resistance if it is more than one drug. If one of these drugs is H, it becomes H mono, H poly regimens. Otherwise, there are mono and poly drug resistance regimens. Okay, so this is what we discussed. What all we have as a bucket from where all we can do the test. The simple ones are the AFP smear. Then we have the nucleic acid amplification test. After that, we have the NCs or the Lanish progresses. Then we have the cultures in the DSP, and you have the latest ones called the next genome sequencing. So that includes all the armamentarium that we have to deal with it. What is important as per our government directions? You have to rule out HIV, you have to rule out diabetes, you have to see whether the patient is having any association with tobacco, and if you have any COVID or any emerging diseases, COVID TB bidirectional guidelines says you rule out TB in the urine flow. Right? How do you go about seeing whether the patient is improving or not? Ideally, when you switch from intensive to continuation phase, you can do it. If at any point clinically you feel earlier, even then you can do your test and see. Okay. So today's what all we are doing? One is treatment of drug resistant, which is very expensive slides. I've gone through 3-4 times. Maybe I could decrease it to a minimum, but I felt all these slides are important, but it is way too more for the other departments. It is actually very important for my department. So I'll just give you the briefs or the algorithms from those slides of 108 slides. We provide all these slides in your mail, but I'll be specifying only on the points which are relevant for you all. Okay? And but you'll have everything in detail there. आज क्या बात? आज क्या बात है? Okay, so drug resistant TB treatment. In general, at any points, if the treatment change, if the guidelines change, everything is available on bbcindia.org. As Dr. Monica told yesterday, we have asked people where you can have the certification of the things also, and you can learn from there and they issue the online certificate for you. So what all is basically important for a drug resistant TB is how do you deal, what are the goals, what is pre-treatment evaluation, what are the generalized technical and operational aspects actually important for the center where the DRTB center is. Please don't have discussions with me. You are all the more noticeable when you are less. So please don't disturb the momentum of my teaching. How do you manage DRTB in adults and children? And then special situations. In general, for drug sensitive TB, you have the same four drugs. You should know you have the charts where it is as per the weight how they are given. For the ease, there are fixed dose combinations provided by the government. For every 15 kg, there is one tablet. And as we specified yesterday, all the tablets as per the weight should be given together. Okay? Monitoring is essential for each and every patient, and there are ways how they monitor on the patient. They visit in person and check for the contacts also. We'll be discussing adverse drug reactions in detail and then treatment outcomes and how to monitor. Okay, so in general, these are all you'll get what is an extensive TB and what is a severe TB and how to define it. But let's go over to this. So, by the government, any of the patient who is there as a DRTB, you have array of people around you. One is the one who treats, then there's the treatment supporter, one who visits, checks everything, and then you have all the aspects of pre-treatment evaluation, treatment initiation, counseling, checking for the adverse drug reactions, how to follow up, and as per the protocol, how to notify or next step. Each and every contact is to be traced, and then post-treatment follow-up. Now, what was happening earlier was they had defined people as counselors and as visitors to the home. So there were only limited number of people. Now what they have said is any member from the house can also become counselor. But they'll guide that person and teach that person what ought to be seen. Okay? And they provide obviously the remuneration for anybody who becomes a counselor for a TB patient. So these counselors can even be our interns who go as per the community health medicine department. They are allotted a family and they can even be the counselors for such patients. So this is where it holds the importance now. Is it readable to all of you? So the first thing is rifampicin resistance is detected. Okay. So normally only rifampicin resistance would be detected from NAT. Why is NAT preferred? Because it has a you can get the results actually within 2 hours. So you can detect early. And most common resistance that is seen as per these studies is to rifampicin. And then we presume that 95% of these cases are actually isoniazid resistant also. So they are labeled as MDRs. On that, if R resistance is there, they are labeled as MDRs. Ideally, LPA and culture is to be done for all of these patients. So then what do you see further? So this FLLPA is the first line LPA. So the first line was for the first 4 drugs. In addition, a second line LPA is also done. Because in case you get first line, patient is resistant to more and more drugs. You have the second line which has a good amount of number of drugs you have and you can select from those. In addition, culture is done. Why? Because sometimes there are discrepancies in LPAs or the sample type and culture is a mandate. Okay? And based on this, what is the drug regimen? Z stands for pyrazidamide, BDQ is bedaquiline, CSF is clofazimine, moxifloxacin, linezolid, and telomerase. Okay? So this is the number of drugs that has to go. After completing the pre-treatment evaluation, PTE stands for pre-treatment evaluation. We check on the mixture or with the culture and DST lab, what is the answer? And what is the answer of the LPA? LPA gives answer in 2 days. Right? If there is no such thing available and you have ruled out any of the exclusion criteria, this regimen is called shorter regimen. Okay? If there is no additional resistance detected, and to the left side in the yellow colored or the mustard colored box, H resistance is detected with, there are two types of genes which are detected for the isoniazid resistance. One is CAT-G, the other is INHA. So either of these is detected or both is detected. And there is fluoroquinolone resistance. F2 is fluoroquinolone resistance, which is not detected. Then you start the shorter oral regimen, which includes bedaquiline. Okay? If in future there is additional resistance seen on the culture, or there is intolerance to any of the drug, or from the government there is non-availability of any of the drug, then we have a longer oral regimen which is given. Okay, so we have completed the left side of our chart. Move on to the right side. From the pink box, after completing pre-treatment evaluation, other exclusion criteria for shorter regimen are seen. If present, we go over to the blue section, we give the longer oral regimen. On the other hand, from the pink, we go over to if H resistance is detected with both CAT-G and INH, or fluoroquinolone resistance is detected, we go over to the longer regimen. So the shorter regimen has a much shorter course, longer regimen goes from 11, around 11 months. Okay? CP depends how you can extend it. So this algorithm will be provided to you. In general, whenever you find, in general for all the other departments except for TB in chest, or the ones who are interested in the medicine department. In general, whenever you find there is resistant TB, just refer to a person who is concerned or who is dealing with all this. This is the grouping of anti-TB drugs. So the basic way of grouping has been choose the drugs from group A. If you find any of the thing which is resistance or intolerance, then we add as per the guidelines. Okay, so group B, group A includes all three medicines, which is chloroquinolones, miraculin, and linezolid. Group B add one or both medicines. You can have clofazimine and cycloserone or teracidone. We often have cycloserine included in our uh, regimens. Group C is add to complete the regimen and when the medicines from group A or B cannot be used. And these include a number of drugs, ethambutol, delamanid, paracetamide. Now, this is to be focused for all the other departments. See, these are the reserved drugs for us for ADD. Imipenem, meropenem, so all the carbapenems, amikacin, ethionamide, protonamide, pass. Similarly, we have a number of other drugs which have a potential anti-TB action, like augmentin. So in general, we say whenever you are including broad spectrum antibiotics, even for the simple URIs, do not give fluoroquinolones. This is to all the ENT medicine, all the guys who are giving for a 5 day or so for any URI which is there. The normal treatment that people follow is the levoflox or pentazole. I would say please learn this. Reserve yourself. Do not use these drugs. You have two things to be concerned about. One is that if this patient is by chance a tubercular infection, there will be partial suppression by these drugs. And then later on, after 2 weeks or after a week, when you think the patient is not responding much or has partially responded and has come back, and you send the AFP sample for the AFP staining or for any of these tests, because of the partial suppression, the bacilli may not be detected. Right? Second thing is, we will allow over the time resistance to be developed to these drugs. So that is why you have to have your own regimes set in your mind whenever a patient comes and you're starting on broad spectrum antibiotics, which is your preference. For example, me, I would prefer ceftriaxone. For you, you have to decide. Do not go over to these drugs which have potential ATT coverage. Okay? So these are the new drugs which we have in our armamentarium. More of important, especially for my team. To be noted that these are not available over the counter outside. Okay, Bedaquiline and Delamanid is not available over the counter outside. It is involved only and only in the government regimens. Bedaquiline they have studied. Now they say the same risk ratio is there for the kids as it used to be for the adults. The main issue with bedaquiline is you have to look for QT prolongation. So earlier we used to have three main things. The patient should be more than 18 years of age, should not have any cardiac issues, and should not be pregnant. So over the time they have come up to you can use below 18 years of age, the rest to remains the same. Okay? Delamanid is a good drug, being highlighted quite a lot over the time. Many studies are going on to use delamanid as a TB preventive drug for the attacks of any positive patient. Yet guidelines are to come for that. Okay? So these are not available outside, only in the government regimens, and that is why the simple answer is whenever you get a patient who is resistant TB, just refer to a center who is exclusively dealing with these. Okay? So this is in general for H mono and H poly DRTB. H mono में only isoniazid से resistance होगी, H poly में isoniazid plus any of the drugs. Okay. For all these, you have 6 months of levoflox, rifampicin, ethambutol, and paracetamide. Answer? So for H mono में isoniazid is being replaced by levoflox. For H poly, you will have to observe which is the other drug, and based on that, you can even modify this regimen if it is out of our season. Right? For MDR-TB or rifampicin resistance detected on that, you have shorter MDR regimen. The shorter regimen includes 6 months of bedaquiline, levoflox, Leronamide, clofazimine, pyrazinamide, isoniazid in high dose, and ethambutol, and followed by 5 months of levoflox, clofazimine, pyrazinamide, ethambutol. The oral regimen goes from which all oral longer regimen. Again, would be modifications of the time into this. Goes for Bedaquiline for 6 months, Levoflox, Linezolid, Clofazimine, and Cyclosin. Now, each of these individual drugs have their adverse effects. We read further how to look for these. Okay? So, these are in detail, we'll be providing you the detailed ones. I'm just giving you only that much information which can be retained first, and then you can have more and more read on whichever thing interests you. These are the drug dosages that we have. Okay? Weights based on weight, how they are to be given. So this is the replacement sequence. If levoflox cannot be used, what next to give? If moxiflux cannot be used, what next to give? If moxiflux and pyrazinamide cannot be used, then what next to give? Okay? How should you follow up? What all is to be seen? So your clinical judgment whether the patient is improving or not, is there any weight gain or not? Smear microscopy, if it was positive, has it converted to negative? Culture, if it was positive earlier, has it turned over negative? What was the drug sensitivity pattern earlier? In case the culture or the smear is detecting now, what is the pattern now? Okay? And wherever implicated UPD is to be done. These are all the tests that we do in follow. CBC, you have to watch for platelets because there are a number of drugs like insulin which decrease the platelet count. You have to see the thyroid function. There are a number of drugs which can alter the thyroid levels in our body. Liver function test, X-ray. ECG, why? Because we have told Bedaquiline, you have to watch for fluid prolongation. Serum electrolytes, especially look for potassium, magnesium, and calcium. Okay? Color vision test for the or related things. And in between as a menu required. So for the MDR treating areas, the core committee includes all the psychiatrists, the dermatologists, the ophthalmologists, include all neurologists to look for any of these adverse effects. So the concerns are there and you have to see those cases, especially if there is pregnancy, if there is a child related. And the general rule in any of the DRTB centers or the model centers is you start the treatment, watch the patient for 7 days, and then you issue a box to their respective centers जहाँ से भी patient को easily दवाई मिल जाए. And then your thoughts provider or the TBS can actually follow up these cases from home. These are regimens. Okay. We'll be providing you all this. This is especially how to monitor for the patients and better today. These are the dosages in the combinations that you have to give. For newer drugs, we have to especially look in for a lot of things. So there are interactions with these newer drugs. So we have to watch for those also. All these charts are there on the tbcindia.org and you can actually follow up these how to look for each and everything. What are the formulations available in the common center? They are patient tailored treatment. So we move over from fixed dose combinations to actually individual drugs and based on the basic issues. Any questions? Now for all the other departments, remember every drug has their own adverse reactions. So for references that comes to these departments, especially look for the drugs these patients are on. Especially look for all the interactions as well as side effects that can happen. So we have a whole detail of how do we go about each and every regimen, but I've told you the brief about how to follow. Okay? Any questions are welcome, otherwise we move on to the adverse drug reactions, which I think most often you all encounter and how should you deal with those.
My question is a bit indirect. You said that most of the antibiotics that have some kind of antitubercular effect should be not preferred for other infections, which makes a lot of sense. But then, if our first line of treatment is Cefixime or any other cephalosporin, and then want to move on to the second line, in that case, then what will be your preference? Because I thought most of the antibiotics were the ones that we go to when the basic antibiotic is not
So
working.
when you are seeing the patient in the OPD on the first go, you do give an antibiotic, right? But you also test the patient to do these investigations which are important as per your case assessment. Right? So by the time this patient comes back to you in next 3 to 5 days and tells you that this antibiotic I'm not responding to, in addition you have those investigations that have to come up. So the
Actually,
X-ray, sputum, whatever.
our problem is that, for example, if we are working in an RHTC, like as a community medicine physician I'm talking about, people do not really go for tests, uh, you know, at least third or fourth visit they will agree to. They won't agree to having a good amount of tests in first meeting. So sometimes we need to give some antibiotics just to make sure that they get better. For example, we get a lot of PID. We get a lot of just basic infections, and because they have been taking those antibiotics from say a quack, sometimes the first line antibiotics are not working, and they are not ready to go for a test, or it is not feasible for them to come from a village to say Subharti, right? So in the end, I just want to do a second line, not more than that.
So the simple concept remains if you are dealing for the first time and you have given a basic short spectrum antibiotic. So the next unit when this patient comes, you do your clinical assessment. Even auscultation and things would guide you. Right? So this patient is not improving at all. Actually consult this patient to get these tests done. So where would the cost issues come? For any of the patients who are going through a private kind of scenario, they X-rays and these would be costly. Phototherapy everywhere is available. NAT has been made everywhere available, easily accessible. And for any of the government setups, they're free of cost. Right? So the photo can easily be done even without an X-ray. Now, if this patient is, you have an approach that way to get an extra allowance, you do get the benefit of that. Otherwise, simple sputum 2 times the sample can be helpful. Now, they have actually, they have made it easily stretched. अगर पेशेंट आपको लगता है कि आज स्पॉट सैंपल दिया और कल कल मॉर्निंग सैंपल के लिए नहीं आ सकता है then within a gap of 1 or 2 hours you can repeat the spot sample. So that is not new to convince that lab technician to do the EFT smear again. And I do, we do normally do in our department, make that patient sit for that time. Your NT will tell you whether this patient is coming positive or not. So for all these cases which we have a high risk, high suspicion, we tell them to sit and wait in our OPDs and we give them answer in 2 hours that you are positive. We need to do for it. So, and for the ones who are coming from outside, already taken treatment from that, now this is your assessment. The patient has already come after 7 days of more blocks. Now you are stuck up. अब इससे तो मेरा भी suppress हो जाएगा. Right? So then you have to take anything. If you feel ये लो blocks चला और मैं इसको दूसरा drug दे सकती हूँ जिसमें anti-tubercular वाला effect नहीं है. Then you can reassess after the next visit whether this patient has improved or not. Not improved, definitely go in for assessment of these things. Right? If approved, obviously you have made the patient aware from those things. अगर ये patient by chance tubercular होगा, अभी आपके ट्रीटमेंट से रिस्पॉन्स भी देगा, तो ये बाद में आएगा. जब ये आएगा तो उस टाइम स्टूडेंट पक्का पॉजिटिव आता है. ठीक है? So we have to assess. So please try yourself to refrain from giving such drugs which are potential active. Any other questions? So this is actually a lot in these slides just to show you what all we have, how do we define, how much studies have gone on, how much details for everything is there, and all these charts are easily available. You have books which come, everything is available on bbcindia.org, and we forward areas. It is more important. At any point, you think you are sleepy and it is going more over to okay, so you can make it discuss that.
Madam, pregnancy or lactation period के सारे दवाई दे सकते हैं?
Sir, normally the government says drug sensitive TB के लिए तो सब चला है. Question always remains on ambulan. So India में this benefit ratio देखें, they say go ahead, do give it. Now for all the other drugs and in general, people think कि breastfeed के through ये चला जाएगा मिल्क और बच्चे के adverse effects होंगे. We say it is a potential preventive for that child. क्योंकि मदर के कंटेक्ट पे रहेगा उसको हो सकता है, बट अगर ये ड्रग्स वाया ब्रेस्ट में जा रहे हैं तो they will prevent the child from having it. They can actually do it. In fact, अगर हम ब्रेक कर रहे हैं, मान लीजिए कोई पेशेंट ले रहा था and then she conceives in between and she stops. So if she is having a tendency to develop into a resistant TB, which is much more difficult to treat, much more longer treatment and much more adverse effects to look for. I noticed yesterday also कि कुछ लोग सो गए थे. आज भी मुझे लग रहा है कि कुछ लोग सो रहे हैं. क्या मेरी आवाज अभी सुनी नहीं लगती है सबको नींद आ रहा है. ऐसा लग रहा है कि डॉक्टर मानिका को बुला लेते हैं, तो मेरे से ज्यादा सुनी था. You can have a lecture with me, and then I'll have it here. So maybe we can have extra content passing this. Dr. Monica, please add. Good morning, everyone. Good morning, everyone. I will be dealing with the TB preventive treatment. उसका क्या बैकग्राउंड है, क्यों हम उसको दे रहे हैं और हमें कैसे एक्टिव टीबी को रूल आउट करना है, टीबी इन्फेक्शन के लिए पहले टेस्ट करना है और कैसे हम उसको इनिशिएट करेंगे और उसके क्या क्या एडवर्स ड्रग रिएक्शन हो सकते हैं. तो फर्स्ट जो हमारा नेशनल स्ट्रेटेजिक प्लान था उसमें देयर वर 4 पिलर्स: प्रिवेंट, डिटेक्ट, ट्रीट एंड बिल्ड. तो प्रिवेंशन वाज द इम्पोर्टेंट पिलर ऑफ दैट स्ट्रेटजी. तो उसमें हमारी स्ट्रेटजी थी कि जो टीबी के कॉन्टेक्ट है उन सबको हम ट्रेस करें, इन्वेस्टिगेट करें, डिटेक्ट जो भी सेकेंडरी टीबी पेशेंट्स निकलते हैं उनको हम ट्रीट करें और आफ्टर रूलिंग आउट एक्टिव टीबी जो हाई रिस्क ग्रुप है उनमें हम टीबीटी स्टार्ट करें. टीबी प्रिवेंटिव थेरेपी. And target was to get at least 95% eligible person है, they should be provided with the TB. As you know, in India, जो हमारी population है more than 15 years of age, the prevalence of TB infection is about 31%. Or you can say कि 1/3 of India's population is already infected with TB. कितना high है prevalence TB infection का. और जो डिफरेंट स्टडीज मिली हैं उनमें इट वाज फाउंड दैट कि अगर हम टीबी देते हैं देन रिस्क ऑफ डेवलपिंग टीबी डिसीज इज रिड्यूस्ड बाय अप्रॉक्सीमेटली 60%. और इन केस ऑफ एचआईवी, अगर पीपल जो ऑलरेडी एचआईवी पॉजिटिव हैं उनमें रिस्क ऑफ डेवलपिंग टीबी इज डिक्रीज्ड बाय अप टू 90% इफ वी आर प्रोवाइडिंग टीपीटी टू देम. तो इतना इंपॉर्टेंट है टीपीटी देना. तो अब है कि हम इसको कैसे दे सकते हैं, क्या कैस्केड है और किस तरह से हमें अप्रोच करना है. तो फर्स्ट जो भी हमारी टारगेट पॉपुलेशन है, टारगेट पॉपुलेशन कौन सी होगी हमारी? who are all the contacts of TB patient, HIV positive, diabetics. These are all will be under target population. तो उन सब में सबसे इम्पोर्टेंट है कि फर्स्ट यू हैव टू रूल आउट एक्टिव TB. TB प्रिवेंटिव ट्रीटमेंट का रोल
एक्टिव टीबी को रूल आउट करने के बाद आता है, क्योंकि हम पहले एक्टिव टीबी रूल आउट करेंगे कि वो प्रिजर्वेटिव टीबी पेशेंट्स को नहीं है। अगर उन्हें कोई भी टीबी का साइन सिम्टम्स मिलता है तो दे कम्स अंडर प्रिजर्वेटिव टीबी पेशेंट। तो उनमें हम पहले इन्वेस्टिगेशन कराएंगे। अगर उन्हें टीबी कंफर्म हो जाती है देन वी हैव टू स्टार्ट द टीबी ट्रीटमेंट और फॉलो अप करेंगे। और लेकिन अगर उन्हें रिजल्ट हमारे सीबी लैब एक्सरे एएफडी सब नेगेटिव आता है, एक्टिव टीबी इज रूल्ड आउट, और या फिर उनमें कोई साइन सिम्टम्स नहीं है टीबी का ऑलरेडी, देन वी लुक फॉर द टीबी इन्फेक्शन। पॉलिसी के हिसाब से मैं आगे डिस्कस करूंगी कि किनमें हमें कराना है नहीं कराना है। कि टीबी इन्फेक्शन के लिए हम उन्हें टेस्ट करेंगे, फिर इवैल्यूएट करेंगे कि टीपीटी उनको दे सकते हैं कि नहीं दे सकते। अगर दे सकते हैं देन वी स्टार्ट द टीपीटी और उनको फॉलो अप करते रहेंगे। अब नेक्स्ट है कि इस टाइम हमारी पॉलिसी क्या है टीपीटी के लिए अंडर एनडीपी, व्हाट इज द पॉलिसी। तो इसमें फर्स्ट हमारी जो टारगेट पॉपुलेशन है पीपल लिविंग विद एचआईवी। तो जो भी एचआईवी पॉजिटिव हैं उनमें जो अडल्ट्स हैं या चिल्ड्रन हैं मोर देन 1 ईयर ऑफ एज उनमें, या फिर जो इनफैक्ट लेस देन 1 ईयर ऑफ एज हैं लेकिन वो किसी एक्टिव टीबी केस के कांटेक्ट में है, और वो और जो भी हाउस होल्ड कॉन्टैक्ट्स हैं टीबी पेशेंट के, पल्मोनरी टीबी स्पेशली, एंड लेस देन 5 इयर्स ऑफ एज है, उन्हें पॉलिसी है कि वी हैव टू स्टार्ट टीबी विद आफ्टर रूलिंग आउट एक्टिव टीबी विदाउट टेस्टिंग। जिनमें हमें पहले टीबी इन्फेक्शन के लिए टेस्ट नहीं करेंगे, केवल एक्टिव टीबी रूल आउट करेंगे और इमीडिएटली वी स्टार्ट द टीबी। नेक्स्ट है हमारा कि उसमें हम जो जीन्स है वो मैं आगे डिस्कस करूंगी। इनमें जो हमारे बाकी कॉन्टैक्ट्स हैं जैसे कि बाकी हाई रिस्क ग्रुप है कि 5 ईयर से ज्यादा के पल्मोनरी टीबी पेशेंट्स हैं, या और हाई रिस्क ग्रुप है लाइक मैलनरिश, डायबिटिक, एल्कोहलिक्स, वो उनमें हम क्या करेंगे, उनमें हम पहले टीबी इन्फेक्शन के लिए टेस्ट करेंगे। रूल आउट को हमें सब में ही करनी है एक्टिव टीबी, लेकिन उनमें हम टीबी इन्फेक्शन के लिए पहले टेस्ट करेंगे और तब स्टार्ट करेंगे टीबी। और इसके अलावा जो ड्रग रेजिस्टेंट टीबी के पेशेंट हैं उनमें हम देखेंगे कि वो टीबी पेशेंट जो फ्लोरोक्विनोन ससेप्टेबल है उसके हिसाब से फिर हम उनको थेरेपी देंगे, या फिर रिफेम्पिसिन ससेप्टेबल है तो उसके हिसाब से हम चूज करेंगे कि हमें व्हिच टीबी इज टू बी गिवन। नेक्स्ट इज कि टीबी इन्फेक्शन को टेस्ट करने के लिए हमारे पास क्या-क्या ऑप्शन है। इसमें देयर आर 3 ऑप्शन, ट्यूबरकुलोसिस सेंसिटिविटी टेस्ट, ईग्रा एंड साइट। तो हमारे किसी के अपने अपने एडवांटेज हैं कि इन सबकी सेंसिटिविटी तो हाई है लेकिन स्पेसिफिसिटी इज हाई ऑफ साइट टीबी और ईग्रा। और इसमें जो बच्चों में है टीएसटी इज अफेक्टेड बाय द यंग एज, लेकिन जो साइट टीबी है इट इज more helpful in case of children and in case of people living with HIV. जबकि TST में it requires HIV tested positive लोगों में TST के रिजल्ट उतने सही नहीं आते हैं। तो लेकिन जैसे मैंने बताया कि जो HIV पॉजिटिव है और हाउस होल्ड कॉन्टैक्ट लेस देन 5 इयर्स ऑफ एज है उनको हम डायरेक्टली ऑफर करते हैं टीबी विदाउट टेस्टिंग ऑफ टीबी इन्फेक्शन। नेक्स्ट इज व्हाट आर द कॉन्ट्राइंडिकेशन, किन किन लोगों में हम टीपीटी नहीं दे सकते। तो फर्स्ट एंड मोस्ट इंपॉर्टेंट कॉन्ट्राइंडिकेशन इज प्रेजेंस ऑफ एक्टिव टीबी। कोई भी हमें एक्टिव टीबी मिलती है तो उनमें टीपीटी देने का कोई यूज नहीं है, तो उसमें वो एब्सोल्यूट कॉन्ट्राइंडिकेशन है टीपीटी। इसके अलावा अदर कॉन्ट्राइंडिकेशन कैन बी एक्यूट और क्रॉनिक हेपेटाइटिस, if we are also using other hepatotoxic medication simultaneously, or there is regular or heavy alcohol consumption, or there are signs symptoms of peripheral neuropathy already present, और जो या फिर जो टीपीटी में ड्रग दे रहे हैं उनके लिए पर्सन इज एलर्जिक और देयर इज हाइपरसेंसिटिविटी व्हिच इज ऑलरेडी नोन टू दैट ड्रग। और टीपीटी देने से पहले we have to counsel the eligible person in the family। उनके साथ हमें शेयर करना है, उन्हें बताना है टीबी इन्फेक्शन के बारे में, उन्हें क्यों जरूरत है टीबी प्रिवेंटिव ट्रीटमेंट की, क्या शेड्यूल होगा मेडिकेशन का, उनको मेडिसिन की एडहेरेंस, सपोर्ट एंड फॉलो अप विजिट के बारे में बताना है। उनको बताना है कि अगर वो टीबी कंप्लीट करते हैं तो व्हाट आर द बेनिफिट, व्हाट कैन बी द पॉसिबल एडवर्स इवेंट, और अगर उन्हें टीबी से रिलेटेड कोई भी सिम्टम डेवलप होता है तो देन व्हाट दे शुड हैव टू डन। और इसके लिए देयर इज अ टोल फ्री नंबर बाय द निश्चय, एनटीपी की नेशनल कॉल सेंटर है निश्चय संपर्क के नाम से।
एक टोल फ्री नंबर होता है, इट शुड बी मेड अवेलेबल टू द ऑल द टीबी पेशेंट, देयर फैमिली मेंबर एंड टीबी बेनिफिशियरी, सबको दे प्रोवाइड करना है फॉर हेल्थ। और टीपीटी स्टार्ट करने से पहले वी शुड इवैल्यूएट द पेशेंट्स अबाउट देयर पर्सनल हिस्ट्री, कि उनको कोई एलर्जिक रिएक्शन तो नहीं है, उनका एचआईवी स्टेटस क्या है, अगर उनका एआरटी चल रहा है ऑलरेडी तो क्या रेजिमेंट चल रही है उनकी, प्रेगनेंसी तो नहीं है, या फैमिली प्लानिंग की बात है, उनका कोई वो कॉन्ट्रासेप्टिव तो यूज नहीं कर रहे हैं, और कोई कोमॉर्बिडिटी तो नहीं है, ये लेना है। हिस्ट्री ऑफ मेडिकेशन लेनी है कि उनकी ऑलरेडी कोई मेडिकेशन तो नहीं चल रही है, because they can affect the उनका साथ में कोई रिएक्शन हो सकता है जो पीपीटी को अफेक्ट कर सकती है। लिवर फंक्शन टेस्ट इज नॉट मैंडेटरी, कोई अगर रिस्क पर है तो उसमें हम करा सकते हैं बेसलाइन टेस्टिंग, और इसके अलावा सोशल एंड फाइनेंशियल सिचुएशन असेस करनी है टू ओवरकम एनी बैरियर फॉर टीपीटी। नेक्स्ट अब व्हाट आर द डिफरेंट ऑप्शंस फॉर टीपीटी। तो हमारे पास 4 ऑप्शंस है टीपीटी देने के। फर्स्ट इज 6H, it means we have to give isoniazid for 6 months daily. Another option is 3RH. इसमें we give isoniazid and rifampicin for 3 months daily. While there are other option is 3HP. In this, isoniazid plus rifampicin. It is not given daily, it is given weekly for 3 months. And another option is 1HP. In this, isoniazid rifampicin is given daily for 1 month. तो इसमें हमारी केवल 3RH को छोड़कर वो 3HP को छोड़कर बाकी सारी रेजिम्स डेली ही है। इसमें in the 6H 1 pill has to be taken daily, while in 3RH 3 pills has to be taken daily, and 3HP में भी 3 pills हैं और 1HP में there are 2 pills. While the 6H and 3RH are safe for pregnant females, but in rifampicin based therapy there is अभी evidence नहीं है कि they are safe in pregnancy or not. So it is not known their safety. So 6H or 3RH we can easily give it safely to the pregnant female. While with 6H there is no interaction with antiretroviral therapy. While in case of 3RH it is contraindicated with some medicines which are given during ART. While rifampicin जो base therapy है उसमें they are contraindicated if patient is on protease inhibitor, nevirapine, NLRTI, and with some other drugs. So these are different options for TPT. So you have to choose according to the patient. Now the potential adverse effect with these TPT can be loss of appetite, there can be fatigue or weakness, there can be abdominal discomfort, nausea, vomiting, dark urine, rash, itching, yellowish eyes, there can be tingling or numbness in the hands and feet. So there can be possible adverse effect with this TPT. Now the post treatment जो जिनको ऑलरेडी HIV पॉजिटिव हैं और उन्होंने टीबी का ट्रीटमेंट कंप्लीट कर लिया है, और तो क्या उनको टीपीटी रिसीव करना है या नहीं करना है। तो ये कि जो हमारे होते हैं जो पीपल लिविंग विद HIV उनमें रिकरेंस के चांसेस ज्यादा होते हैं, तो इसलिए दे शुड गेट टीपीटी जिससे कि रिकरेंस ना हो आफ्टर कंप्लीटिंग द कोर्स ऑफ टीबी ट्रीटमेंट। नेक्स्ट इज द फीमेल जो प्रेग्नेंट है, तो क्या उनको टीपीटी दे सकते हैं? यस, प्रेगनेंसी इज नॉट अ कॉन्ट्राइंडिकेशन फॉर गिविंग टीपीटी, चाहे एचआईवी है या नहीं है, दे कैन स्टार्ट विद टीपीटी ड्यूरिंग एंटीनेटल पीरियड एज वेल एज पोस्टनेटल पीरियड। इसमें भी आइसोनियाजिड और rifampicin आर सेफ टू यूज इन ड्यूरिंग प्रेगनेंसी, बट इनमें पैराडॉक्सिन, अगर आइसोनियाजिड दे रहे हैं तो पैराडॉक्सिन सप्लीमेंटेशन इज रिक्वायर्ड फॉर ऑल द बेबी। Next is if they are using any contraceptive, तो क्या रोल है? अगर वो ओरल और हार्मोनल कॉन्ट्रासेप्टिव पे हैं तो rifampicin and rifampicin जो इंटरेक्ट करती हैं और एफिकेसी को रिड्यूस कर देती हैं, तो you have to use an alternate like Dimpa for every 8 weeks or high dose of estrogen or other form of contraception like barrier contraceptive या IUCD like copper T। और जो फीमेल्स ऑलरेडी हार्मोनल कॉन्ट्रासेप्टिव इम्प्लांट पे हैं, तो we have to reduce the interval of replacing, अगर 12 वीक्स है तो उसको रिड्यूस करके 8 वीक पे प्लेस करना। Next is if a patient is having liver disease, then what we can do, as isoniazid and rifampicin are associated with liver toxicity. तो उनमें हमें बेसलाइन लिवर ट्रांसएमिलेज वैल्यूज देखनी है। तो अगर ये मोर देन 3 टाइम्स ऑफ अपर लिमिट ऑफ नॉर्मल है तो हम एक कॉशन के साथ स्टार्ट कर सकते हैं टीपीटी। अगर एंड स्टेज लिवर डिसीज है तो यू हैव टू डिफर द टीपीटी, टीपीटी नहीं स्टार्ट करना है। ड्यूरिंग एक्यूट हेपेटाइटिस so you can defer the TPT until the acute stage is over. While isoniazid वाली जो therapy है, it can be given to the hepatitis B positive and hepatitis C positive. Next, a patient of renal failure. Renal failure की patients हैं, इनमें we can give isoniazid and rifampicin or rifampicin eliminated होते हैं biliary excretion से, so TPT can be given in standard doses in patient with renal failure. Next is people who are living with HIV. HIV के साथ क्योंकि रिफामाइसिन बेस्ड रिजीम में प्रॉब्लम होता है, तो इसलिए रिफामाइसिन और रिफापेंटिन को हम इपिविरनास के साथ दे सकते हैं। लेकिन जो रेलटेग्रावेर रिसीव कर रहे हैं उनमें हायर डोज चाहिए होगी रेलटेग्रावेर। नेक्स्ट इज बेबीज जो कि टीबी पॉजिटिव मदर के न्यूबॉर्न होते हैं, उनमें हम क्या कर सकते हैं, इफ मदर इज टीबी पॉजिटिव एंड न्यूबॉर्न इज नॉट वेल, तो वी हैव टू रेफर टू या स्पेशलिस्ट और पीडियाट्रिशियन। लेकिन न्यूबॉर्न अगर ठीक है, कोई उसमें साइन सिम्टम्स नहीं है प्रिजम्पटिव टीबी के, देन टीपीटी शुड बी प्रोवाइडेड। और बीसीजी वैक्सीनेशन अगर हम टीपीटी दे रहे हैं तो इसलिए ये नहीं है कि बीसीजी वैक्सीनेशन नहीं दे सकते, तो बीसीजी शुड नॉट बी डिलेड इफ newborn is on TPT. लेकिन साथ में we have to give pyridoxine। और अगर HIV मदर इज HIV और पॉजिटिव और नेविरापिन भी अगर हम दे रहे हैं, then we should give 6H। और मदर अगर एंटी-टीबी ड्रग दे रही है तो she can breastfeed the baby but using precautions like she had to use mask and cup etiquette should be considered। जो टीपीटी ले रहे हैं उनमें हमें क्या क्या फॉलो अप करना है, मॉनिटरिंग करनी है। तो जो all the individuals who are on TPT they should be followed up, like screening of all the symptoms of TB like cough, fever, night sweats and weight loss, any side effects। और अगर कोई भी symptom TB का आता है then they should be referred for the further evaluation of active TB or drug resistant TB। और in some cases में we have to do NAT and LPA for diagnosis of TB or drug resistant TB। और इसके लिए नेक्स्ट में टीपीटी का डैशबोर्ड भी है जिसमें ऑल द इंफॉर्मेशन रिगार्डिंग टीपीटी शुड बी एंटर्ड इन द नेक्स्ट डैशबोर्ड। एंड देयर आल्सो आईसी मटेरियल प्रोवाइडेड बाय द नेक्स्ट, उसमें होर्डिंग, बैनर, लीफलेट और जो टिप बुक्स है, हेल्थ बुक है, हेल्थ केयर वर्कर की ऑल आईसी मटेरियल रिगार्डिंग टीपीटी इज अवेलेबल ऑन द साइट। और फॉर ट्रीटमेंट सपोर्ट जो ये टीपीटी हम दे रहे हैं इसके लिए टीपीटी सपोर्टिव इंसेंटिव भी मिलता है कि अगर एक पेशेंट का टीपीटी कंप्लीट कराते हैं तो उसके सपोर्टर को ही गेट्स 250 रुपीस फॉर टीबी प्रिवेंटिव ट्रीटमेंट कंप्लीशन ऑफ। थैंक यू। एनी क्वेश्चन रिगार्डिंग इसलिए सर डिफरेंट रेजिम्स हैं। आइसोनियाजिड वाला है वो 6 मंथ का है, 3HP है वो 3 मंथ की भी रेजिम है, 6 मंथ एंड 3 मंथ की रेजिम है डिपेंडिंग ऑन द पेशेंट। There are a few things that I would like to say. One is I do appreciate that my nursing department is there from my department, nurses are there to learn. I do appreciate that attitude towards this learning. And community medicine के department का participation. Though all these things were mandated by the government because teaching of TB has gone from respiratory department towards medicine department, and all over there is emphasis on medicine and pediatrics to learn more. But on the contrary, we are seeing actually enthusiasts from community medicine and my nursing team. I really appreciate all these things. पहले आज से 10 साल पहले there used to be a lot of confusion while dealing with this. गवर्नमेंट में ऑल्टरनेटेड लॉस होता था, प्राइवेट में हम लोग डेली रेगुलर चला रहे, बहुत कंफ्यूजन था, आगे नहीं हो सके थे कि लॉस नहीं देना है, गवर्नमेंट वाला नहीं है उनका अपने रीजंस थे फॉर गिविंग दिस आर ऑल्टरनेट बिकॉज दे हैव टू डायरेक्टली ऑब्जर्व इट एवरीवेयर द पेशेंट कैन नॉट कम एवरी डे लीविंग द जॉब कमिंग आफ्टर यू आर टेकिंग बट द प्राइवेट वी यूज्ड टू थिंक ड्रग रेजिस्टेंस और ये सब चीजें कम है अगर हम डेली रेगुलर दे रहे हैं बिकॉज हम ऑल्टरनेट दे रहे हैं हमने डोजेस बढ़ाए so over the time daily regimen has come into the view. Then comes the question of कब रेजिस्टेंस सोचना है आना है कि earlier it used to be without all these good drugs being available in the government armamentarium and the standard way that how would people follow. It used to be more preferred by the private people to have their own treatments. So it did have I mean, sort of side effects कि कुछ लोग ने इसको aberrant use किया. Now everything is standardized. So you have to think, अगर आप अपने clinic में हैं, what you have to do? If you believe that you have to treat this patient, जो आपको सब एक्स्ट्रा काम करने हैं वो है एक फिजिशियन ने सब कुछ नोट करना सारे ड्रग्स का इन एंड आउट जानना सारे रेजिडेंट्स का जानना उसके चार्ट्स रखते हैं कि हमने क्या चीज फॉलो करनी है और क्या चीज गलत हो सकती है और नहीं करनी काउंसलिंग ऑफ पेशेंट्स एवरी टाइम in addition you have to look for contacts and give PPT these are your add-ons what are your benefits for every information to government you have 500 for initiation of treatment you have 500 rupees for completion of treatment you have 500 rupees and your patient will get 500 rupees per month as per the fixed portion so then for all this you have to maintain the fixed portion if you feel you are not able to do this just simply refer to a consultant. Okay? And then every time you have to look for is my patient improving or not improving. For all the months where you give empirical treatment, remember, if your patient is not improving or partially improving, either your diagnosis has to be reevaluated, or we are missing something, or the patient is not compliant. So we look for all these things. बहुत सारे पेशेंट्स में कैंसर के ऊपर से टीबी होता है हम टीबी का ट्रीटमेंट दे रहे हैं पार्शियल इंप्रूवमेंट हुआ कैंसर मिस हो गया बहुत सारे पेशेंट्स में हमने एम्पिरिकली चला दिया बिकॉज हमने उस ओपेसिटी को टीबी समझा बट दिस वाज कैंसर देयर इज वेयर द गिल्ट कम्स कि उसको इतने टाइम कैंसर का ट्रीटमेंट नहीं मिला एंड कैंसर इज स्प्रेड so be aware of all these things so be cautious when you give the patient treatment ऐसा नहीं है कि कोई फीवर नहीं जा रहा उसको एटीटी चला दो ऐसा नहीं है कि कोई डायग्नोसिस नहीं बन रहा तो उसको एटीटी चला दो you have to exclude all other diagnoses before giving these empirical treatments okay? And on the other hand also if you have a pus which is every time coming sterile so these are definite indications for tuberculosis sterile pus repeatedly अब पहले हम स्टकअप हो जाते थे क्योंकि एक्स्ट्रा पल्मोनरी सैंपल्स में हमें एयरबी पॉजिटिविटी कम दिखती है बट अब हमारे पास बहुत कुछ एनालिटिकल है वी हैव कल्चर्स वी हैव हिस्टोग्राफिक कैन बी पुट ऑन द कल्चर्स ओके वी हैव एक्सिनोम सीक्वेंसिंग वी हैव पीसीआर वी हैव n number of things that you can do it so don't just do blind ones and do not do as we emphasized yesterday TB gold and quantiferon and all these things no there are be specific on your end. So let's go over to management of adverse drug reactions. Wherever you feel it is overdue for you, I can simplify it in simple words and leave it from there. You have every of the text available with you on the online and we provide you with the PPT. I can then make it brief and give you the terms. So these are in general the recommended regimens for drug-resistant TB. And this is the whole list of adverse drug reactions that we can have. There are much less for the drugs that we use for drug-sensitive TB. That is why those four drugs are preferred. Okay, that is why we say कि aberrant पे मत चलिए शुरू में. अगर किसी पेशेंट को फर्स्ट फोर ड्रग्स नहीं टॉलरेट हुए हैं तो हमने थोड़े टाइम के लिए उन ड्रग्स को रोक देना होता है, let the patient revert back to normal and then sequentially restart the drug one by one and see the tolerance. Okay? That is the standard way. So you have a lot of array of the adverse drug reactions and which drug is responsible is additionally given. Remember, all areas have to be reported to the Unico Pharmacovigilance Group. So you have WHO operational handbooks, and these handbooks are for each and every aspect. They are there for diagnosis, they are there to look for adverse effects, they are there to guide you policy. Any of your patients who is not doing well, and you clinically assess that patient नहीं बता पा रहा है कि adverse drug reaction है, but you clinically assess in your follow-up that this patient is not improving, this can have a number of things. Either we are into a wrong diagnosis, or the patient is having adverse effects, or the disease is worsening, or you can have iris. We did discuss iris yesterday. Okay? So for all the mild reactions, you can have an add-on treatment. पेशेंट को रैश हो रहा है, एलर्जिक रिएक्शन हो रहा है, आप उसको साथ में सेट्रिजिन या एंटी एलर्जिक दे सकते हैं. But for any major reaction, hold the drug there itself. If you feel these cannot be managed at home, this patient actually requires sedation. So we have literally had cases in the past where एक ड्रग है उसको एक दो तीन चार कुछ पे टॉलरेट नहीं हो रहा है. ठीक है, so better have this patient admitted in front of you. Stop those drugs, keep a watch, give the alternate ones to have a control on TB if they are really too sick, and then sequentially restart in front of you, see which is the offending drug. क्योंकि FTCs के साथ यही problem है कि fix those combinations में you will not be able to pick up which drug is causing it. So hold that FTC, give individual drugs as per the weight, and then see. And that too, everybody has a different way of dealing. So some people get, जैसे हमने H reduce करना, H full dose में, half full dose में, then H full dose में. Some people, for me, I did tell you, I prefer small dose first, then slowly increase the dose. Let the patient tolerate this. But remember the counting of the whole duration goes from where the patient is able to tolerate all four together for drug sensitivity. So the total duration gets extended. अगर पेशेंट को बीच में एक महीना नहीं टॉलरेट हुआ है, मान लीजिए मार्च में शुरू किया था, पेशेंट को दिक्कत हो गई, हमने होल्ड किया, हमने सीक्वेंशियली रीस्टार्ट किया, और फाइनली पेशेंट अप्रैल से खाना शुरू कर रहा है ड्रग सेंसिटिव TB, एंड ऑफ अप्रैल से, तो सारा ड्यूरेशन 6 मंथ्स मिनिमम वाला अब से काउंट हुआ. So QT interval we see in these three drugs. At any point you feel you are not able to decide these, just refer to a cardiologist. Mention that this patient is on this drug. So these are general guidelines how to see how much is the QT period, and then you go on from there. These are the most common symptoms that we find: nausea, vomiting, not of gastritis. So if it is a gastritis issue, you can add on your antacids and you can see the response. If it is ATD intolerance, despite your these drugs, the patient won't be improving. Get the liver function test along with. See, again, इसमें भी बहुत सारा what the book says, the text says 5 times value तक आप tolerate कर सकते हो. What you have to see. अगर 2 times हो गया और आप फिर भी उसको बोलो खाते जाओ, patient is not improving, all is getting moderate, the patient will have non-compliance towards you as well as to drugs. So then you have to counsel them. explain them the reason. Or you can get them admitted, watch in front of you. If the patient is gradually moving back to normal, fine luck. Not moving back to normal, hold the drug, give the patient time to heal, then restart sequence. And these are general ways of how to do. So these are the offending agents for hepatitis. Okay. They have to look for if already patient is having deranged liver function, how to manage. If the patient is developing sterility-induced hepatitis, then as I told you, 5 times is what takes place, but then you have to watch for how. And all the things is mentioned in the environments. For limits on it, you have to look for myelosuppressors. So if the HB is decreasing, platelet count is decreasing, you have to look for this. So anyway, if you start off these drugs, you have to tell them कि इतना frequently आपने ये blood test कराना है. Okay? So keep this in your mind. Similarly, Zitronamide and PAS. PAS is not much used nowadays, but for all the patients who will be on resistant TB regimens, will be having zitronamide, so then you have to watch for thyroid. So that is why it is said in follow-ups you have to do their thyroid SSL. Definitely, patients do complain of arthralgias or pyrazinamide, fluoroquinolones, bedaquiline. You have to counsel them, repeatedly counsel them. But arthralgias normally are not to the level that you have to stop the drug for these things. So, your counseling would help. A lot of drugs can cause peripheral neuropathies. That is why pyridoxine is there to heal in between. In addition, you can have the role of the multidisciplinary team is always there in all such. Remember these psychotic symptoms. But these you have to have a watch. पेशेंट को साइकोटिक सिम्टम्स हो रहे हैं हम जबरदस्ती उसको दवाई खिला रहे हैं तो पेशेंट सुसाइड ना कर दे साइक्लोसिरिन की स्पेशली ध्यान रखना है यू मे हैव टू होल्ड ड्रग्स फॉर दिस आइसोनाइजिन से बहुतों का साइकोसिस बढ़ जाता है टेक द ओपिनियन होल्ड द ड्रग चूज द ऑल्टरनेटिव especially for these drugs are which can cause suicidal abuse. Nephrotoxicity. So, although now the injectable drugs are away from those regimens, but if you are giving as a replacement for some other drug, you do have to look for nephrotoxicity. You have to look for hearing loss, vestibular toxicity can be there. In addition, पहले जब हम स्ट्रेप्टोमाइसिन रेगुलरली देते थे तो 2 एग्जाम थे पेशेंट से हेयरिंग लॉस पूछना पेशेंट को एक टाइम से चला के देखना तो लुक फॉर एनी एग्जाम any gate disturbances. So all these have to be looked for. Audiometry करा लेना. And these are the mentioned thresholds as per the otoscopy and audiometry. Optic neuritis. So this vision loss wherever it happens is actually irreversible. So you have to guide the patient, you have to ask them everything. And there are cases where you are stuck. We do use the multidisciplinary team approach again then. We have had cases almost 20-25 years, 5 girls reporting to us, actually referred from the neuro team, having tuberculosis there and having all these features of optic neuritis along with drug interactions along with. In addition, you can have all these. Now, there is a sequence given on how to replace. I know it is an overdue. So you want me to discuss and I can go forward. Otherwise, we will be giving you this. In case you face anything, refer to your text and then replace. There are ways of how to which drug to replace when what is found. This is the replacement sequence that is given in text. Anywhere you are stuck up, do have a core committee meeting. Do discuss with all for any of the case and then take a final decision for yourself. If it is a private dispute. Any questions? My department team has to know email etiquette. Only then you will get the references and then you will do it accordingly. With your question, we move on to the next part. Or you want to break in between? Chai aa rahi hai, samosa aa rahe hain. Don't worry. Thank you. Thank you.
हो गया. पाँच मिनट का ब्रेक है, क्या करना है?
और दो
हैं? हैं?
और तो 5 से ज़्यादा हो जाएगी.
दोबारा स्टार्ट करो.
उसका ये वाला बोर्ड लगा दो वाला. तो उसी को लगा दो. इससे कर दो.
चलने दो. थैंक यू.
इससे लगा
उस
दो.
पे लगा दो, ऐसे छोड़ दो. बोर्ड पे लगा दो.
इम्प्रूवमेंट दिखना चाहिए, इतना मुझे नहीं दिखा। So I had a कुछ गड़बड़ है इसमें। Now this boy does not have history of contact at home. पहले हम सोचते थे ड्रग रेजिस्टेंट टीबी में नॉर्मली घरों में कंटैक्ट होगा, कोई ऐसा बच्चा होगा, इसका कंप्लेंट पूछ लिया जाता सब कुछ था। Then I got CT done for this boy. Because X-ray में original color तो heal हो गया, but I found him neoplastic, which was very small. CT में he had very small documented pockets, edge and each other. I did present this case in one of the CMEs, but these were eye-openers for us. For years I have been battling such questions कि clinical improvement नहीं आती, तो मैं drug resistant TB का इलाज कैसे शुरू करूँ? ये मेरे clinical basis पे drug resistant TB है, but I do not have a proof. Now without this proof, government will not help it. Otherwise, if I write कि ये clinically मुझे drug resistant TB लग रहा है, unless I have a proof on the hand or in case or anywhere, government will not give the drug resistant TB. I was stuck on the What is CT done at peripheral three opacities? अब ये tappable fluid नहीं है। Now what to do? So I insisted to the radiology team कि मेरे को आप यहाँ से pleural biopsy दे दो, ठीक है? Fortunately, this boy got convinced because he came to a staff who knows my reputation over the last 6 years. He convinced the boy. We got the biopsy done. अब ये biopsy, I know as a fact this is I'm not condemning the government. I know they have a lot of workload. ये extra कल में टीम का केस था, ये अपने government में culture में छोटा 2 months I would have to start. So we had this the new kid on the block next to him sequencing with us. We did go forward with this. Biopsy को सीधा भेजा next genome sequencing. What do they do? वो culture में पहले bacteria को बनाते हैं, उसके बाद ठीक basis पे detect करने का resistance start. And to my utter shock, this patient came as pre-HDR. Now imagine, why did I present this in CME's work? अगर इसको हम नहीं pleural biopsy कराते, उसके रिस्पॉन्स पे क्या वो इम्प्रूवमेंट हो रही है? ये पेशेंट कितने टाइम मेडिसिन खाता? पहले 6 महीने खाता कम से कम, मैक्सिमम को एक्सटेंड करके इसका सीपी बढ़ा के 2 महीने कर देता, 8 महीने खाता। उसके बाद ये कन्विंस हो जाता कि मेरा एटीटी कंप्लीट हो गया, तो घर चला जाता है। आपको लगता है कि ये रेजिडुअल ओबेसिटी रह गई है एक्सरे में। You would have also left it like this. Another few months or year later, we would have come with a rampant resistant TB bacilla और जल्दी कितनों को इन्फेक्ट करता है यहाँ पे। So this is how the clinical scenario and your pictures make a difference. Whenever you are in doubt, repeat the test. You have a whole lot of armamentarium to repeat. So this boy was finally treatment completed क्योंकि हमने इसको गवर्नमेंट रेजिमेंट में भेजा। Insisted them now with this report of pre-HCR, please give him the bedaquiline regimen. We have had difficulty because this cycloserin, this boy had issues because of chlorophas. He had darkening of the skin. He was barely for the 24-year-old boy. एकदम डार्क कम्प्लेक्शन हो गया है, जॉब छूट रही है, तब इसको कन्विंस करके हमने एडमिट किया बीच में। आफ्टर पार्शियल ट्रीटमेंट टेकन ही वाज लाइक मैं ड्रग्स छोड़ दूंगा। अपने पास किया, काउंसिल किया, जो चीजें लग रही थी लैब टेस्ट के बेसिस पे करने को सप्लीमेंट की वो सब। Finally, this boy has completed the treatment. Repeat X-rays and CTs have shown the improvement. And then finally, we are content कि ये treat हो गया। So you do have such cases. So remember, any of your error on that side can actually let this pre-XPR mutant bacilli to go from him to any other contacts. And because these standardized formats have been given, there are the ones who are the rods providers or the treatment providers are not as advocated as you. So your decision making does make a difference. So scientific terms practices by Dr. Monica. After this, I am free. All questions are.
exactly.
गुड मॉर्निंग एवरीवन वंस अगेन आई होप आप लोगों ने चाय समोसा सब लोगों को मिल गया है नाउ यू आर एक्टिव फॉर द नेक्स्ट सेशन जो भी आपके फ्रेंड्स हैं प्लीज कॉल देम इन 5 मिनट्स वी आर स्टार्टिंग द नेक्स्ट सेशन ऑन एक्स्ट्रा पल्मोनरी ट्यूबरक्लोसिस
बंद कर दो
extrapulmonary tuberculosis. In this, I am only giving the important points about the extrapulmonary tuberculosis. Every type of extrapulmonary tuberculosis have its own algorithm. If you require, we will share with you. So in most of the cases, you have to refer the case to the specialist. But important is that when you have to suspect the extrapulmonary tuberculosis of different causes.
शकील जी
First, the overview. Total tuberculosis के cases होते हैं उसमें extrapulmonary tuberculosis constitute about 15 to 20% of the total TB cases are of extrapulmonary tuberculosis. और उसमें भी जो pleural tuberculosis है, it is also classified as extrapulmonary. और
संजय कैमरा थोड़ा आगे नहीं जा सकता और
tubercular lymphadenitis and pleural effusions are most common among the extrapulmonary tuberculosis.
संजय तुम्हारी फोटो भेजे हैं
Every demonstration difficult होता है because there is a low bacillary load. So these extrapulmonary tuberculosis may be possibacillary. तो इसमें जो क्लिनिकल फीचर्स हैं उसके
इसमें तो उसकी तरह लग रहा है हीरो है नाम बोलिए उसका
इसमें नैट और लिक्विड कल्चर यूजुअली प्रेफर किए जाते हैं एज अ डायग्नोस्टिक टेक्निक
बताओ किसकी तरह लग रहा है
इंफॉर्मेशन एडिशनली रिक्वायर्स सम स्पेशल इन्वेस्टिगेशन depending on which organ is
बता दूं किसी तरह लग रहा है तो कहते हैं हाँ भाई क्या कह रहा था
excision or biopsy on histopath examination used for cytology biochemical analysis smear examination and X-ray of the involved region or ultra USG for abdominal tuberculosis. It is diagnostic algorithm. So I am discussing only the few points. If you are suspecting it is a case of presumptive extrapulmonary tuberculosis, you have to take appropriate specimen from the site. If it is available, specimen is available, then you can go for CBNAT. CBNAT में अगर माइक्रोबैक्टीरियम डिटेक्ट होता है, तो you have to look कि रिफैम्पिसिन सेंसिटिव है या रेजिस्टेंट है, या रिजल्ट आर इनडिटरमिनेट. अगर सेंसिटिव है, तो it is microbiologically confirmed extrapulmonary tuberculosis. You have to start treatment according to them. अगर rifampicin का result indeterminate है, then you have to repeat the CBNAT on the fresh specimen. The second is indeterminate आता है, then you can again take the sample and send it for liquid culture. अगर rifampicin resistant आती है, तो you have to manage according to the guidelines. और अगर CBNAT नहीं available है, then you can go for liquid culture. You can go further according to the result of culture. Positive आता है या negative आता है. तो positive आता है, then TB is confirmed microbiologically. Negative आता है, so it can be low TB or अगर clinical suspicion है, you can use of other diagnostic tool or make the diagnosis of clinically diagnostically, or you can think of alternate diagnosis accordingly. Next is first is adult abdominal tuberculosis. कि कब हमें सस्पेक्ट करना है कोई भी organ which is involved in the abdominal cavity, blood, lumen or peritoneum may be affected by TB. In case of peritoneal tuberculosis, there can be abdominal distension, there is history of pain abdomen and history of fever. While in case of intestinal tuberculosis, there can be recurrent intestinal colic, there can be partial or complete intestinal obstruction, there is history of chronic diarrhea, history of weight loss. You can feel a palpable mass on abdomen. There can be history of lower GI. In case of esophageal tuberculosis, there may be history of dysphagia, gynophagia, hematomasis, and other constitutional symptoms of tuberculosis you may get. In case of gastroduodenal tuberculosis, there is gastric outlet obstruction and history of GI. Another is in case of perianal tuberculosis, you may get simple or complex perianal fistula. There is history of persistent discharge. There are fistula which reoccur after multiple surgery. Then you may suspect perianal tuberculosis. In case of pancreatic tuberculosis, you may have history of abdominal pain,
obstructive jaundice, dilated pancreatic or bile duct with pancreatic mass or cyst, and a history of other constitutional symptoms of tuberculosis. In case of hepatobiliary tuberculosis, there is a fever of unknown origin, hepatomegaly, jaundice, ALP may be elevated, there can be hepatic abscess. Another common tuberculosis is lymph node tuberculosis. When you have to suspect if there is a lymph node is enlarged more than 1 centimeter in the neck or axilla or in the groin, if lymph node are more than 2 centimeter, redness may or may not be present, there can be fluctuation and sinus discharge. And lymph node tuberculosis may or may not be associated with fever, weight loss, night sweats, and cough. But there is important is a history of similar swelling in the past, or there is a past history of tuberculosis you may get, and there is also a history of contact with a patient with diagnosis of tuberculosis. Another is adult musculoskeletal tuberculosis. In this, you may get spine tuberculosis, in which there is a history of persistent localized pain in the spine for more than 6 weeks, and history of night pains. There is local tenderness or cold abscess. There is recent onset deformity in the back. To make it a neurological deficit, there is persistent heaviness around the waist or girdle pain. There is maybe history of fever, cough, weight loss, and night pains, and also history of contact with a tuberculous case.
इतना मतलब है उसे, इतना
In
मतलब
case
है।
of when other joints or bones is involved, there is history of persistent localized pain and swelling for more than 6 weeks. If it is usually monoarticular joint involvement, there may be discharging sinus. There is frequent swelling with or without inflammation. There is painful restriction of movement of that joint. There is wasting around the area involved. There is history of fever, cough, weight loss, and night pain. And also, similarly, history of close contact with the active TB case. In case of adult pleural tuberculosis,
उसका
you
साउंड
may
लाइव
get
है
history
उसे,
of
लाइव की
fever,
टेंशन नहीं कुछ।
uritic chest pain,
सबसे बढ़िया लाइव।
cough, breathlessness, anorexia, weight loss, and also similarly history of TB contact, like previous. On examination, you will found the area is dull on percussion, breath sounds are decreased or absent on that area. In case of tubercular meningitis, then you have to suspect the patient is having fever, and duration of fever is 5 days or more. He is having history of headache, vomiting, altered sensorium. There is a cranial nerve palsy, hemiparesis or any limb weakness, seizure, neck pain, and stiffness. And always inquire in case if you are suspecting tubercular meningitis, also inquire about the associated feature like constitutional symptoms, active fever elsewhere. If there is a past history of tuberculosis or taking Valium, if there is a history of contact with active TB case or positive history of an HIV about the socioeconomic status, if patient is living in a high endemic area. And then you have to refer the patient to a facility where the lumbar puncture facility and CT facilities are available. In case of pericardial tuberculosis, what will be the symptoms when you should suspect is there is a history of fever, cough, restlessness, uritic chest pain. It may be associated with the weight loss, night sweats, difficulty on lying down. There is a past history of contact with active TB case. On examination, you may get tachycardia, increased JVP, hepatomegaly, ascites, and peripheral edema. There may be a pericardial friction rub and distant heart sound present on the CVS examination. Complication of pericardial tuberculosis may be constrictive pericarditis, cardiac tamponade, and other complications are also there. So better is you refer to a specialist. Other is cutaneous tuberculosis. When we suspect the cutaneous tuberculosis, is there is the presence of ulcer or discharging sinus over a lymph node or bone or joint. There may be persistent asymptomatic reddish brown lesions for more than 6 months duration, which may be scarring.
or there may be persistent body or varicose season of more than 6 months of duration. There can be extracutaneous involvement also, lymph node and lung involvement may be also there, and there may be other system may also be get involved like bones, PIT and CNS. So we get cutaneous tuberculosis in the form of lupus vulgaris, scleroderma, or varicose veins. In case of female genital tuberculosis,
अगले किलो में बैठ गया
when you have to suspect the genital tuberculosis, if there is a history of
चैनल
infertility,
है इसने तो कर दिया
it may be primary infertility or secondary infertility. There may be chronic lower abdominal or pelvic pain. There may be amenorrhea or menstrual disturbances, abnormal history of abnormal vaginal discharge, history of other constitutional symptoms of TB like fever and weight loss, other features which are related to extragenital TB like abdominal, CNS, bone and lymph node, etc. So you have to suspect the genital tuberculosis and all these if you get these issues. In case of intraocular tuberculosis, then you have to suspect the intraocular tuberculosis. If you have ocular symptoms like blurring of vision, there is a redness on the eye, there is history of photophobia, pain in the eye, there are floaters and flashes of light are there, then you can suspect the intraocular tuberculosis and you have to refer the patient to an ophthalmologist for eye examination in detail to assess the visual acuity and rest of the details about.
दिया होगा ना तो वहाँ जाओगे
And these are the links for your references. If you want to go into the detail of extrapulmonary tuberculosis, then these modules are available on the tbcindia.gov.insights. And you can download the module from there on extrapulmonary tuberculosis. All the algorithm of extrapulmonary tuberculosis are there. I am not discussing that
दिया है
because
पागल की हो रही
ये
है
बहुत ज़्यादा हो जाएगा आप लोगों के लिए समझने के लिए क्योंकि extrapulmonary
पागल की हो
tuberculosis के अलग algorithm है. So if you want, we can share it.
रही
Thank you.
टाइम लग
Is
सकता
there
है
any question, query about extrapulmonary tuberculosis?
पता नहीं कितना लगेगा करता हूँ
तो उसके लिए जो मैंने हिस्ट्री बताई थी उसके हिसाब से आप सस्पेक्ट करके बेटर है कि यू हैव टू सेंड द पेशेंट टू अ डर्मेटोलॉजिस्ट फॉर confirmation of diagnosis and further evaluation. In all these cases, mostly you have to refer to a specialist. After.
संजय तो कोई बात करें ना पीछे उन्होंने दिखा दो बात कर रहे
टीवी नहीं पर ले आ सकता और किसी में कॉम जा सकता. The second is, earlier we used to think that extra community normally they are drugs responsible for drug sensitive effect. But over the years things have changed. They are coming out as drug resistant TB as well. So that is why our emphasis is wherever you suspect, better tissue diagnosis. But all the extra community ones you need to tissue or the fluid which can be sampled to it. Because unless you do it and you treat the drug sensitive ones, this patient, if it is actually drug resistant, you will be wasting a whole lot of 6 to 8 months before finding diagnosis. As regards the pictures and how should we go about, everything is there. You want to focus on any particular aspect, genital urinary or dermatology or anything. That's all available on the site. In case needed, we can have, as we have already said, one-to-one discussion with the clinician and we can move on.
Next one.
अच्छा my God. और दिखाओ किसी को फोकस करके और क्या क्या कर रहे हैं सबको दिखाओ चलो अच्छा ठीक है ये भी ठीक है और सोरा से दिखा दो दिखा दो चीज़ तो दिखा दो दो बल्लू में हाथ लगा है
In brief, we have covered almost all topics with you. We do have a diagnostic designated microscopy center. We do have all the things that are used in PV in our department at our institute. We are in PRTQ center and we have almost all the diagnostics. We do have 3 or 4 cases under which the patients can be benefited.
सब्जी के हाथ लग गए तो छूट
Dr.
सकता है
Krishna
किसी से
ने
हो सकता है
related वाला बता दिया था GI वाला. There is one case in my department going on for genetic disease. For all the first time cases, and next year they are current first year they are as submitted as protocol, that is approved. Even all those newer tests can be done on first time cases. So almost all the things have been included. We do tend to have more and more pieces related to TB in future. All the departments are welcome for that. As per the government, for any of the operational research cases, up to 5 lakhs of grant is allowed, and for all the pieces, 30,000 is allowed. So any of the departments can plan their research, the students can plan their research, even if their ICMRs and others do have grants available for TB, that could be helping you for your cases. In general, whenever you deal with such patients, remember these are difficult to take medicines. It is not as easy to compare this and both हैं patient को खा लेना है and then forget it. Not listen to his complaints. There are a lot of issues that come with these medications. So be empathetic towards these patients. Only then they will have a good compliance to their treatment and to your follow-ups that are recommended. So many of the cases are welcome. We do have first line LPA, second line LPA, next genome sequencing all at our central lab. There are a number of projects or clinical trials which are into the process. If you are able to get those, even those can be done for you. After this, we close it for a year. And remember, certificates will be given to only those who have attended both these days. That's as per the government and management. The certificates will start giving after a day or two, or maybe you can come to the NU unit and Shakil will give it to you from Tuesday onwards. That was fine. Anything needs to be addressed, can be. Thank you. Thank you all of us for participating.
खत्म खत्म भी ना बंद कर दो